Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today, we continue with our weekly flashcode section, a space to explore the world of acute coronary syndromes and primary angioplasties. Let's get started. This week we have a 91-year-old man with a good quality of life who had a personal history of arterial hypertension, severe aortic stenosis treated with a percutaneous valve prosthesis in 2019, and chronic ischemic heart disease manifested as stable angina in the context of a single-vessel coronary disease and treated percutaneously with two overlapping stents in the proximal anterior descending artery. He came to the emergency room due to chest pain and was diagnosed with ST segment elevation myocardial infarction of 3 hours of evolution. When he arrives at our unit, the patient is stable, although chest pain persists. This is the electrocardiogram of our patient. As you can see, it is evident that there are alterations in ventricular repolarization. These alterations are expressed as elevations or descents of the ST segment in some leads and suggest that there is an acute myocardial injury. Can you identify these alterations? Well, let's start at the beginning, because the first thing that stands out is the existence of a complete left bundle branch block. This is important because, as you know, in patients with chest pain, new onset complete left bundle branch blocks can be the electrocardiographic manifestation of an acute coronary occlusion, while previously known blocks can mask repolarization alterations. Unfortunately, in this case we did not have a previous electrocardiogram to establish the comparison, but it was not necessary either, since there were electrical signs that suggested the existence of an anterior STEMI. These are the ST elevation of more than 5 mm in V3, V4, and V5, and the specular descent of the ST segment in inferior leads. But how clinically important is this? Well, very simple. The STEMI is the usual clinical manifestation of a complete obstruction of a coronary artery and constitutes a cardiological emergency where every second counts. Thus, our main objective should be to open the artery as soon as possible, either through fibrinolysis or primary angioplasty. In this case, a cardiac catheterization was performed, and, as you can see, there were no angiographically significant lesions in the right coronary artery. This is logical, taking into account that the electrocardiographic alterations were in the anterior wall. So we are going now to take a look at the left tree, but first, it is worth stopping for a moment to carry out an academic exercise. Do you know what the radiopaque and cylindrical structure that dominates the SIM is? Because of course it is not a coronary stent, although it is implanted in a similar way. It is actually the percutaneous aortic valve prostheses that have been previously described in the history. These prostheses are known as TAVI, and as you know, they have supposed a true revolution in the world of interventional cardiology, as they have allowed us to treat patients with severe aortic stenosis who could not have been treated before. And although there is much more to say about it, this is a topic for another video. Let us now return to our clinical case for today. This is the left coronary angiography. As you can see, the circumflex artery is patent and does not present significant stenosis. However, the anterior descending artery is occluded proximally, just at the level of the stents that had been previously implanted. This, as you can imagine, coincides with the repolarization alterations described in the electrocardiogram. In this way, now that we know where the obstruction is, we can only treat it. The first thing is to pass an angioplasty guide wire through the occlusion. Sometimes the passage of the guide wire partially unclogs the artery and allows us to see part of the distal bed, but this is not the case. So, an in-stent predilation was performed in order to regain blood flow and reevaluate the extent of the disease. Thus, it was possible to open the main artery, and it was observed that the disease extended to the middle anterior descending artery and the first diagonal branch, which, in fact, was still closed. For these reasons, a guide wire was advanced to this branch and the vessel was predilated, managing to restore blood flow and showing that this branch had modest caliber and development. For these reasons, It was decided to revascularize the main vessel by placing two overlapping drug-eluting stents in the proximal and middle anterior descending artery, protecting the diagonal branch with a guide wire, and incarcerating its ostium with a provisional stent technique. And this is the final result. As you can see, we have recovered the flow of the artery after the implantation of the stent, obtaining an excellent angiographic result in the main vessel and an acceptable result in the secondary branch, without peri-procedural complications. At this point, some might wonder, why was the secondary branch not treated with a stent, taking into account that there is plaque and dissection of the vessel at the proximal level? And the answer is very simple. The flow is good, and the vessel is not very developed, which is why implantation of a stent is not recommended. In this way, with the artery open, the left bundle branch block persists, but the ST segment elevation progressively decreases, and the patient's pain disappears. The emergency is resolved, and with it, our chapter. It has been all for today at Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!